From the JAMA Network, this is JAMA Internal Medicine Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Internal Medicine.
Hello and welcome to our listeners around the world. You're listening to JAMA Internal Medicine Author Interviews. Thanks for joining us. I'm your host, Dr. Jerard Kneifati-Hayek. I'm an editorial fellow at JAMA Internal Medicine and guest host of today's podcast. In this week's episode, we'll be discussing a narrative review of a patient-centered approach to supplemental oxygen therapy in the outpatient setting. I am joined today by Dr. Anand Iyer, who is the senior author of this review. Dr. Iyer is an associate professor in the Division of Pulmonary, Allergy, and Critical Care Medicine at the University of Alabama at Birmingham. Dr. Iyer, welcome to the podcast.
Thanks for having me, Jerard.
In our daily practice, we often encounter patients who are on oxygen or need oxygen therapy. When we see oxygen levels drop below 88%, we may reflexively place an order into the ether and hope our patient gets some sort of oxygen therapy. Dr. Iyer, in your review, you help us better understand this whole process. The part of the review that really stood out to me was your patient-centered approach, which considers things like functional status, goals of care, and more. Can you walk us through that framework?
Absolutely. And I think that's one of the central messages we hope readers leave is our person-centered approach. This is based on the data. First off, the supplemental oxygen landscape is a mess. It's a mess for patients, their families, and us as clinicians. And from our findings, we came up with 6 domains that we think are very important for clinicians to consider when they're prescribing supplemental oxygen. Those domains are healthcare values and preferences, functional status, frailty, and mobility, cognition and supplemental oxygen education, physical symptoms, psychological and social impact, and finally, caregiver support. When you prescribe oxygen to a patient in the outpatient setting, just putting in the order and putting that prescription, as you said, into the ether is woefully insufficient. There's so much lack of education for the patient. There's so many missed opportunities to assess the needs of the patient regarding their functional status and their mobility. And though we intend as clinicians to impact their mortality, we may counterbalance that by significantly worsening things like their functional status, their mobility, their isolation, and much more. Oxygen is a critical step in the trajectory of a serious illness, and it deserves much more time and effort for us so that our patients feel empowered and they can improve their independence and quality of life rather than the other way around.
How can clinicians apply this when counseling patients?
We've come up with several different ways to do this. And if we were to take each piece of the domain apart, starting with something like healthcare values and preferences, we've based this on the geriatrics 5Ms approach. And one of the 5Ms is what matters. So understanding what matters to the patient regarding their goals and preferences for serious illness and how oxygen can impact that, that's important. And you can start your advanced care planning discussions and serious illness communication at that point. Secondly, functional status, mobility. When that patient walks into clinic, are you assessing their mobility as they're walking into the room, getting up in and out of a chair, measuring their activities of daily living? Because as I've talked to my patients with COPD, rolling that oxygen tank around the house is not easy, or out into the world is not easy. It's heavy. It can be a burden, and it can actually limit their mobility. So do they actually have the strength to lift it up? And are you as a clinician thinking about the portable options? Are you measuring cognitive impairment and how that could impact their ability to understand education, and including respiratory therapy as a interprofessional team support to help educate them? Are you measuring their physical symptoms like breathlessness and fatigue? And is oxygen meeting those needs? And if they're having refractory symptoms, engaging specialist palliative care. Then psychological social impact, assessing if adding supplemental oxygen is increasing their loneliness and their isolation, trapping them in their homes. It's like a tether that they often feel keeps them at home when it should be the other way around. And then are they still working? And is oxygen impacting their ability to continue employment? And do they need better devices? And then finally, do they have a caregiver? Are you engaging them in the conversation? It's incredibly burdensome to them too. And supporting their loved one who is living on supplemental oxygen. So are you giving them respite care resources? Those are just some high-level examples, but in our paper, we include a lot more, and even in the supplemental table, practical considerations for that.
Could you tell us about the indications for supplemental oxygen and how should a clinician go about assessing a patient they believe might benefit from it?
If you need help with that, our figure 1 in the paper provides a simple and practical way that clinicians can answer the question, does my patient or does this patient need supplemental oxygen?
For many clinicians, oxygen is kind of a black box where the order is signed, but there's limited involvement beyond that. What pearls do you have for clinicians when it comes to counseling patients who are newly starting supplemental oxygen?
That is probably the most important question here. And I would draw readers to our patient perspective. Mary is that patient expert who lives with a chronic lung disease and uses supplemental oxygen. And her story at the beginning is just eye-opening about what happens when her provider, physicians, ordered oxygen. And I run a clinic in Birmingham for people who are largely uninsured. It's a county-supported program down the street from the academic medical center, and I see this all the time. When you order that oxygen and you fill out the forms and you think that's done, after that point, there is minimal education that happens for the patient and their family. Oftentimes, the durable medical equipment delivery driver is the only person they're going to get in contact with who may or may not offer much education about the devices. They'll send a stationary oxygen concentrator to plug into the wall with tubing that goes around the house, a sufficient supply of tanks that are quote unquote portable, but some could be 10 pounds or more. And they're supposed to be like, okay, good luck. Even in Mary's perspective, she had a family member that said people on oxygen don't work. And so this person's a middle-aged patient trying to continue her life. And the delivery driver is telling her, well, that's it. You're done. You're at home oxygen. Now you're trapped in your home. And so they don't get much of any education. What do the devices look like? How are they supposed to measure their oxygen? What are they going to do when there's equipment issues? And what if they're running out of tanks? And my patients, and for my outpatient setting, experience this a lot. And they don't get supplies that they need to continue their lives accordingly. And if they do, they're often these smaller tanks that don't last very long, or they have to tote that big tank around. And so now they're trying to balance everything. And they reach out to patient support groups online to answer all their questions, as Mary described in her perspective.
I'd like to finish our conversation by talking about the negative stigma of having to be on oxygen. How do you approach this with patients?
That's an important question, too. Oxygen represents a critical point in the trajectory of serious illness. And people don't look at it as a happy moment. Often they talk about it as the end or some major change in their quality of life and their just independence overall. And they see the stigma of the tubing going over their nose and feel like everybody can now see me as a person who has a chronic illness. Whereas before they might have had COPD without oxygen, now they have COPD with oxygen, so it has a stigma to it. And our framework encourages clinicians to destigmatize oxygen, to encourage patients about the importance of it, to help with some of their symptoms, their mortality, judging by the evidence, and figure out ways to destigmatize it. So we provide in the supplement some online resources for patients to go to, or clinicians can go to provide that resources to their patients. There are support groups, as they described, of people who are wearing portable concentrators and running marathons. And in my own research, I've had one lady who had to the tubing and was so embarrassed by that she wouldn't go to church. But with the help of some of my team members, we were able to figure out ways to hide the tubing a little bit over her nose and her ears. And she felt more empowered and started to go back to church more with her oxygen, wearing her pearls and her necklace and everything. So it's a bit about having that conversation and understanding, helping your patients understand it's important to them, but also what else is important to them and how you can counterbalance the two things.
What should we focus on next as a professional community in terms of research and implementation?
Yeah, we have a section devoted to future directions, and some of this is research, some of this is advocacy. So from a research standpoint, we need more evidence across cardiopulmonary conditions into ILD and other states. We need research on innovative portable oxygen devices that can last long, are cost effective, because my patients in an underserved clinic in Birmingham are not going to be able to get a portable oxygen concentrator. So we need those entities to provide cheaper options for patients that are approved. We need research on exertional desaturation that takes into account all the different impacts that it can have for our framework and how that exertional desaturation can be treated with supplemental oxygen. And then we need advocacy. So the SOAR Act, SOAR, is still needing support in legislation to combat a lot of the gaps that we identified in our paper, all the way down to allowing different professionals the ability to educate patients. More support, finally, for liquid oxygen. It's quite amazing of a option that can really help patients with higher oxygen flow needs, like interstitial lung disease, get the support they need. In some ways, it's a very portable option, can be a portable option. It just lasts very long. Oh, and then I mentioned about pulse oximetry. Can't go without stating that there have been numerous systemic injustices described about pulse oximetries and how they don't adequately measure oxygen saturation in people with darker skin tones. And so there's been a push to, make sure companies are changing those devices so that they can adequately measure the oxygen saturation levels in those populations. So we describe all of that in our future directions section in the paper.
Thank you. Those are really great things to look forward to. I am Dr. Jerard Kneifati-Hayek, and I've been speaking with Dr. Anand Iyer about supplemental oxygen. You can find a link to this article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.